and then we will, I'll turn it over to you, Mary Kay. Welcome back, everybody. We're going to give people a few seconds to join before we get started. Okay, Mary Kay, you can take it away from here. And then Tina, you can start sharing whenever you want. Thank you.
Thank you. Good afternoon, everybody. Welcome back. I'm pleased to be able to introduce this afternoon Tina Didino. Tina is the medical case manager at REM Ohio. She has worked with people with Prader-Willi syndrome for over 23 years, providing literally thousands of hours of hands-on medical, crisis, behavioral care, and overall support. Tina has also been the co-author of an article on the dangers of positional asphyxia, particularly with people with Prader-Willi syndrome. She has attended dozens of national conferences, presented at both providers and general conferences, served as a YAP counselor and behavior specialist. And for the past 4 years, when we have been fortunate enough to be together, she's been instrumental in the conference's success, serving as a nursing medical coordinator. And we're thrilled today that she's able to join us in a virtual presentation. So please help me welcome Tina Didino today.
Hi, everybody. How are you? It's good to see some old familiar faces and some new faces. Let me get this started here. So today we're going to be talking about medical issues in Prader-Willi syndrome, what you didn't know that you needed to know. When I went to start doing this presentation, I thought to myself, oh, here's all of this information I want to review with everybody. As providers, I think it's very difficult because there are so many medical alerts out there, and it's hard to, first of all, know them all. And I haven't seen anybody like actually kind of put it all together in a presentation. So that was my hope for you. So I had big aspirations when I started to do this, and I thought, I'm going to make a great presentation for everybody, and I'm going to make slides, and I'm going to make pictures, and it's going to be phenomenal. And as I started to look at the table of contents here, I thought to myself, nobody wants to see pictures of any of this, so I'll just do the slides. So there's your reason why you have the slides and not the pictures. Without further ado, we're going to get started talking about high pain tolerance. Please know that not everyone with Prader-Willi syndrome has high pain tolerance, but most of them do seem to have a high pain tolerance. And as a result of this, illness, injury, and infection may not be noticed right away. So you might not notice that there's an issue until it's very serious. As a caregiver, you have to have a keen eye. You have to know your individuals inside and out. Subtle comments and changes that you pick up on can be very, very beneficial to preventing hospitalizations. Somebody might make a comment like, my ear feels funny. I've actually seen this happen. Individual said, my ear feels funny. Staff didn't think anything of it because it was just a passing comment. Well, about a week later, she repeated herself, my ear feels funny. And that staff reported it to me. At that point, she was seen in the emergency room. It had now been, remember, a week later. By the time she was seen in the, I apologize, urgent care, not emergency room, her ears were both infected, and they were infected so badly that her eardrums were actually blistered. So those subtle comments, I just can't stress to you how important that it is that those get looked into. Other comments, I have a black spot on my tooth. sometimes, what is this? I hate the what is this comment because you never really know what it is. So usually it's somebody pulling out part of their tooth in the middle of eating dinner. I feel hot. That can be a sign of illness. My stomach hurts. Keep in mind that because of the pain tolerance issues in Prader-Willi syndrome, they also have a very difficult time generalizing the pain. So they can't say, it hurts right here. They say, you say, oh, you're having pain. Yeah. Where does it hurt? Here and here and here. So just because they can't pinpoint the pain doesn't mean that the pain isn't real. Another huge issue that as providers we need to pay attention to is if somebody comes up to you and says, if I don't feel good, can I still go to the movies tonight? Now, that is typically a sign that something's going on with them, but they don't want to say something's going on with them because they really don't want to miss that movie. Fractures can be an issue in people with Prader-Willi syndrome because they have early osteoporosis. A lot of times I hear staff saying, you know, well, she could still move it, so it must not be fractured. And you hear the individual saying, well, I could still move it, so it must not be fractured. Being able to move it if you have high pain tolerance is not a sign of the person not having a fracture. If you see swelling and bruising, I mean, if there's a bone visible, definitely you want to have that evaluated. Our individuals can show only very subtle signs of injury and fracture. They might have little to no limping, maybe just a general slowing down. I remember seeing a woman who we couldn't figure out why she was walking so slowly. What ended up happening is she had shattered her pelvis, and all we saw was a generalized slowing down of her movements. So these things can be quite serious. Open wounds, you always want to monitor open wounds for any sign of infection. Look for redness, swelling, drainage, odor. Is that warmer than the rest of the infected area? And sometimes they have open areas and we don't know that they have open areas. So you always want to kind of be on the lookout, scanning pants, shirts, bed linens, chairs, fingers, and any other place that the individual frequents, looking for drainage, because that can be a sign that there's an open area. Dental issues are pretty common in people with Prader-Willi syndrome because they have that thick, sticky saliva, which causes a lot of caries, also known as cavities to those of us lay people. Monitor for facial swelling. Facial swelling can be a sign of an abscess, which is an infection in the gums. And they should seek dental care as soon as you see an abscess. It can be quite painful. It can actually impact their eating. Broken and cracked teeth can be relatively common. And bruxism. Bruxism is a fancy word for grinding your teeth. And what I see a lot of is our individuals grind their teeth to the point where they cup them out. So you know how when you look at your teeth, you see the 4 points and the surface is relatively flat with a little tiny dent. Well, over a period of time, that constant grinding and grinding tends to cup the teeth out. So when you look at the tooth, it's like the outside shell with a huge hole in the center. So you've got the 4 walls of the tooth, and then you can see like yellow called denti in the bottom of the tooth. There are oral devices that you can get from a dentist to help eliminate some of that bruxism, especially at night. They tend to be pretty expensive. Not all insurances will cover them. You can go to CVS and you can get a nighttime mouth guard. Something is better than nothing is the way I feel about it. When you do go to CVS though, you need to mold the brace, you need to mold the device. So you'll boil it in some water and then you let it cool a little bit, then you put it in their mouth and then you tell them, okay, I want you to bite down on this and I want you to suck in. And that's a little bit hard for our individuals to do. But once again, something is better than nothing. But the biting and sucking at the same time of the device is a little bit tricky. So how do you know if your individual is in pain? So our individuals' bodies feel the pain. and experience the pain, but their brain doesn't always feel the ouch. That's the best way I know to explain it. The exception is always going to be a paper cut just to make you look like a liar. They get a paper cut and all of a sudden they're, oh my God, it hurts, which I know a lot of us feel that way about paper cuts too. Some symptoms that they might exhibit instead of saying ouch would be they would become pale, clammy, sweaty, their heart rate can increase. They could just all of a sudden pass out. I've had this happen leaving a dentist office after extractions. All of a sudden, the individual and I were walking and talking, and he just hit the ground. Luckily, with this individual, like I said, you're the eyes and the ears. With this individual, I knew him well enough that I looked at him and was able to grab him prior to him hitting the ground. There was a look on his face that I knew what that meant. If you're looking and their shoulders where their elbow's supposed to be, chances are they're in some pretty significant pain. Any swelling, any limping or abnormal range of motion are also good indicators of pain. Which leads us to the question, if somebody has high pain tolerance, do they actually need pain medication? Yes, pain medication can ease the stress on the body. Pain medication can help lower a high heart rate. Some of our individuals do not do well with narcotic pain medicine, and they may require a lower dosage. Narcotics may make them extremely lethargic, and it depresses their respiratory system. And the system that's already compromised, you're depressing it further. Narcotics can also cause issues with gastric motility. So when you're considering pain medication for an individual, you want to be sure to consider the lowest dose possible that makes that person comfortable. When I say narcotics cause issues with gastric motility, this can cause constipation, whether you have Prader-Willi syndrome or not. In addition to constipation, it can also slow down the movement of the stomach and the intestines, which we'll talk about a little bit later when we discuss gastric issues in Prader-Willi syndrome. Our individuals may have an exaggerated response to medications. Anesthesia can be a particular concern. General anesthesia is not as worrisome as conscious sedation. Usually if you're getting some sort of sedation in an office setting as opposed to a hospital. When we talk about sedation and anesthesia, it takes them longer to wake up. They have a small oral cavity, so if you're getting general anesthesia and they're putting a tube down in so that you can breathe down into your trachea, that small oral cavity can create a problem, as well as the thick saliva that they have when they're pulling the tube out. It can actually cause some choking, and that saliva can kind of block the airway. Loose teeth can cause a problem because they can break off during the process of intubating or extubating them. Obesity and apnea cause breathing problems in our individuals. Anytime they're having an outpatient procedure, you should always consider having them stay overnight after surgery to receive some additional monitoring. Our individuals also have the poor muscle tone, also known as hypotonia, which causes a poor cough. We want everybody after anesthesia to be able to cough well, to clear their airways and to prevent pneumonia. And obviously, with the hypotonia, this can be a problem in our individuals. Psychiatric medication, our individuals react, they have increased side effects on lower than normal doses of medication. I've seen people's eyes start to move independently of each other. I've seen very pressured speech, very excited, kind of like the way I'm right now trying to talk to you. So our individuals become very, very excited, easily excitable, rubbing their face to the point where creating an open area. And I can't remember, many years ago, I was listening to someone talk at one of the conferences, one of the physicians talk, and they said, start low and take it slow. And I think that that's a wonderful way to explain how to approach psych meds in our individuals. Start low and take it slow. Respiratory concerns in Prader-Willi syndrome, obstructive sleep apnea. During sleep, your gravity takes over because you relax, your muscles relax, and this allows the tongue and surrounding soft tissues to fall back in the throat, and that can obstruct your airflow, thus obstructive sleep apnea. Our individuals, when they're overweight, this causes a higher risk to them because the muscles are relaxing, and not only is it relaxing that throat and blocking off the airway that way, but your lungs aren't expanding as much. Their lungs aren't expanding as much as they should. Some symptoms of OSA would be snoring and daytime sleepiness. Weight loss can help with this. Sleeping on their side, having a tonsillectomy or an adenoidectomy can help because sometimes those tend to block off the airway in the back of your throat if they're too large. Sleep studies should be considered by the PCP if you have snoring and daytime sleepiness. Another way to treat obstructive sleep apnea is through CPAP. This is a mask that goes on your face. It goes either covers your mouth and your nose, or it just covers your nose. And what it does is it provides pressurized air, and it comes in with like tremendous force to help keep those airways open while you're sleeping, so that the relaxation doesn't cause the closing off of the airway. There are also oral devices now that can help prevent the tongue and the soft tissue from closing off your airway in your sleep. Central hypoventilation is also a possibility in people with Prader-Willi syndrome. This is a disorder of decreased breathing rate or death. So what happens is when our individuals are sleeping, they tend to breathe more shallow. And this causes problems with daytime sleepiness also. And if it's significant, this can cause problems with elevated blood pressure in your lungs, which is something you really don't want to happen. Reflux and aspiration can be a problem respiratory wise. When you lay down and you sleep, the acid from your stomach can come up your esophagus, and it can get down into your trachea and then enter your lungs. That can cause pneumonia. It can also, if anybody has ever had reflux issues in the middle of the night, it can also block off your airway for a minute. That acid makes it so that you cannot breathe, and it's very scary to wake up to. Scoliosis can also cause respiratory concerns. Typically, you look at a 70-degree curve in the spine. At that point, it is definitely able to affect your breathing. Oxygen should be given with great care in our individuals, because oxygen, we always think, oh, oxygen's great, it can help you with your breathing. In our individuals, it can actually stop their breathing altogether if it's given in if too much of it is given. I apologize. You want to make sure that the hospital staff and the anesthesiologists all are aware that our individuals might be at risk if they receive too much oxygen. So carbon dioxide levels in people with Prader-Willi syndrome that have apnea or decreased breathing, are severely overweight, or have COPD can be pretty high. So your carbon dioxide level is high. That is actually what tells your body, your brain, to breathe. In people who are severely overweight, once again, not as much in the people who are not. So once the carbon dioxide level is high and it is no longer telling your brain to breathe, your body becomes dependent on low oxygen levels to breathe. Therefore, if you give too much oxygen, the brain will stop telling you to breathe. Vomiting. 2/3 of our individuals are not capable of vomiting. You think to yourself, hey, well, they can't vomit because you need your diaphragm to vomit, and that's a muscle, and you need your diaphragm to push and say, everything out of my stomach. Not the case. Vomiting is actually, and I actually stole this from Dr. Loker, vomiting is actually a complex reflex involving the stomach and central nervous system. Your vomiting center is located in your hypothalamus, which is affected in Prader-Willi syndrome, as well as other hypothalamic activities. So vomiting is also impacted. Now, reflux and rumination is something that we see in Prader-Willi quite frequently, where the food is regurgitated, rechewed, and reswallowed. These behaviors don't involve the hypothalamus, and vomiting can be, but not always, a sign of a very serious problem in people with Prader-Willi syndrome. Please know that as a result of the neurological function and vomiting, that Ibuprofen will not work in case of poisoning, and repeated doses can cause problems in our individuals. Next up is gastroparesis, which is huge in our individuals. It's thought to be pretty common. You think about the process of eating. When you eat, the food enters your stomach. The stomach then contracts and releases, mixing your food with the acid in your stomach to help digest the food. It breaks it up, and then it sends it on into your intestines. With gastroparesis, the stomach contractions slow down, and this causes the stomach to empty the food slowly. The contents of the stomach, being the food, can then build up, leading to distension in the stomach or stretching of the stomach. This can also slow down the intestines, leading to constipation. So distension is dangerous because, remember, our individuals don't get that full feeling to tell them to stop eating, and they can also have a pain tolerance. They also possibly have a high pain tolerance. So the stomach can stretch or dilate until it cuts off the blood supply to the stomach. Once you cut off the blood supply to a portion of your stomach, that portion can die. It's also called necrosis. This can then lead to a perforation or a rupture of the stomach. Once that rupture occurs, the gastric juices and the food then enter the thoracic cavity, the body cavity, and medical care is needed immediately. Once you hit that point, death can occur very, very quickly. The technical term for this is gastroparesis with dilation and necrosis. There are some conditions that can actually slow down the emptying of your stomach. Diabetes can slow it down, hypothyroidism, narcotic pain medication, as we talked about earlier, can also slow this down. Binge eating or eating large quantities of food can also cause gastroparesis and a stomach rupture. Nobody knows how much food is too much food is what's really scary. The other part about that that's very scary is that thinner individuals seem to be at an increased risk for gastroparesis, stomach rupture as a result of binge eating. So those of you who have individuals who are in their goal weights and doing a great job, know that if they have a binge eating episode, they're at a much higher risk of these severe gastric issues. Now, the symptoms that you would watch for would be nausea, vomiting, abdominal fullness after eating, pain, and a hard, rigid abdomen. So the abdomen would feel very tight. If you poked at it gently with your finger, it would seem like they were maybe smuggling a basketball in there. That's what a hard, rigid abdomen is. We've already discussed that because they don't feel full, they have the high pain threshold, the chances of you recognizing there's a problem early on is pretty difficult. If one of your individuals is experiencing any of those symptoms, they should be seen in the emergency room quite urgently. If they look ill and they don't finish a meal, I highly recommend calling 911 because at that point, you definitely have no time to waste. Once you arrive at the ER, a lot of times the severity of the illness is not taken seriously because our individuals mask their symptoms so well, and they mask so many of their symptoms. You want to be sure that you have your medical alert book along with you, along with the algorithm that tells the emergency room exactly what to do. That's page 31, and it is titled Evaluation of Individuals with Prader-Willi Syndrome with GI Complaints. I like to tell the emergency room physician, any person with Prader-Willi syndrome that presents with abdominal pain is to be treated as an acute abdomen until proven otherwise. Now, that makes you sound very, very smart. Sometimes you sounding smart is going to attract their attention. If you look, that's an acute abdomen. but that's not what we're talking about here. Sounds pretty fancy. What that means is when you take somebody with Prader-Willi syndrome into the emergency room is supposed to treat them like there is something very, very wrong with them until they're able to do testing and prove that there's nothing wrong with their bellies. Whereas if you and I go in, they're just kind of looking to see if something's wrong. But they're going to treat our individuals as if there is absolutely 100% something wrong with them. Choking is a huge problem in our individuals, and our individuals can be predisposed to it because of that thick, sticky saliva, as we talked about before. Anytime you're sneaking food and swallowing it quickly to avoid being caught, our individuals don't always chew well. They eat very fast. They take large bites. They have poor oral muscles and poor swallowing muscles and a poor gag reflex. There are some things that can be done, though, to prevent choking. You want to encourage a slow eating pace, encourage cutting food into small bites, encourage sips of liquid after each bite. This is called the pace and chase method. So you're going to pace yourself, take small bites, and take sips of liquid afterwards. All of your staff should be trained in the Heimlich maneuver. If we haven't talked about enough issues, body temperature regulation abnormalities. So because the hypothalamus is impacted, obviously one of its other functions is temperature regulation. So what does this mean to you as a caregiver? Their bodies don't respond to illness or injury as a person without Prader-Willi syndrome. Water temperature is difficult to gauge. Temperature of food is difficult to gauge. And it's also very difficult for them to gauge what clothing to wear based on the weather. So we'll break that down for a minute. So during illness, temperature can be very low in our individuals with Prader-Willi syndrome, which can be life-threatening. A temperature less than 95 degrees Fahrenheit is kind of your indicator, but really you should base that number on your individual's baseline body temperature. Some people do run a little bit lower. It's dangerous to run lower because your internal organs can end up damaged and won't work properly if your individual's body temperature is too low. When their temperature is too high, this can be a sign of a very serious infection. It can be a sign that they've had an infection that has entered their bloodstream and they would need to be admitted for IV antibiotics. I do recommend that any fever be evaluated in an emergency room. Typically, their temperature would be below 98.6 degrees Fahrenheit. What I usually see is temperatures in the 96-degree range. You want to check your individual's temperatures for a few weeks to obtain a baseline temperature for each individual. Be sure that you and the physician know what that baseline temperature is, and be sure that it's documented in the person's medical record. If a person's temperature is always around 96.4 degrees, and then all of a sudden they're experiencing a temperature of 99, this could be like 101 degrees in a person whose body temperature is normally 98.6. Conversely, it's also going to help establish what's too low of a temperature for that person. Either way, it's going to help with receiving proper medical care for your individual. Once you get to the ER, once again, here I go talking about that medical alert book. That should be your Bible anytime you're dealing with any medical issues with your individuals. You want to have that book open and ready to discuss temperature abnormalities. You want to know your facts, discuss the baseline temperature of your individual. There are times when you're going to go into that emergency room, and aside from the temperature, you know that something isn't quite right, but you just can't put your finger on it. As far as gauging water temperature, if the temperature from the water is too hot, unintentional scalding can occur. If the water temperature is too cold, you can lower the body temperature. You don't really see a lot of this because our individuals tend to feel cold frequently, and they wouldn't typically take a cold bath or a shower. One of the concerns, though, is if they're getting a reinforcer for showering and bathing, they might not tell you that the water temperature is too cold. They might actually take a cold shower. You really don't want to lower their body temperature. You want to monitor that water temperature regularly and consider a govern for the temperature of the water so that scalding is not an option. You can cap the water off at a lower temperature than would be in your personal household. Can't gauge the temperature of food. When you're serving and heating food, if it's too hot and you go to serve it to your individual, they'll always say, oh, it's okay, I'll let it cool down. They won't. They won't because they want to eat it, but they also won't because they really can't gauge the temperature and tell whether or not it's cooled off enough or not. This could cause burns to the lips and the mouth, and burns can turn into new areas to pick. They can't gauge their clothing based on the weather temperature. They're susceptible to overheating and hypothermia, which is obviously, we've already talked about getting too cold. They'll wear winter clothes on a 90-degree day, and they'll go out without a coat in the wintertime. I just experienced this last week. It was 90 degrees in Cleveland, and one of our individuals was in the van, came to pick up another individual. I went to say hello, and there she was sitting in this van on a 90-degree day in a full-on winter coat with a fur hood pulled up over her head, explaining to me that it's too cold and there's air conditioning at her place of employment, so she needs her winter coat. It took a great deal to get the coat back from her, but I was successful. Yay. You want to try to create and post guidelines for when they can exercise outside, when they should wear a lightweight coat or a winter coat, whether or not they should wear thermals, whether they should have no coat. Another thing that is nice to do is to discuss environmental cues with them. For example, if you could see your breath outside, you should be wearing a coat. Adrenal insufficiency. Anytime your body or our individuals' bodies are injured or ill or overworked, causing them stress, your body produces cortisol in response to that. If your body does not produce enough cortisol during stress, you can enter into an adrenal crisis. You see here the symptoms of an adrenal crisis. And unfortunately, as you're looking at those symptoms, you're probably like me going, they're not going to really tell us half of these symptoms. I tend to rely on the low blood pressure, the slow, sluggish movement, confusion as an indicator when a known person with adrenal insufficiency is experiencing a crisis in the very early stages. Please know that adrenal insufficiency can be fatal. I've read many studies on adrenal insufficiency, and it doesn't seem to be clear if there's a high or a low prevalence in adults with Prader-Willi syndrome, in part due to the diagnostic testing. The diagnostic testing that's done for this, they don't respond appropriately to. So it's very difficult to tell if it's a false positive, it's a false negative. Just know that it's a possibility and it can be fatal if it's untreated. People that have adrenal insufficiency are treated with hydrocortisone via oral tablets on a daily basis, or they can be treated with cortisol on an emergency basis, or both. Skin picking. This is very common to people that have Prader-Willi syndrome. Not all of our individuals do it, but for those that do it, the severity ranges from minor to Texas Chainsaw Massacre. You can have mosquito bites lasting for 10 years. I've seen people pick out part of a muscle. Our individuals will use devices to help pick: pen caps, paper clips, scissors, nail clippers, fingernails, fingers, probes from toothbrushes, thumbtacks, anything they can use as a device. If they're dedicated enough, they will use that to help pick their skin. Usually our individuals have favorite pick sites. Maybe it's the base of their nose. Usually it's fingers. Many people with Prader-Willi syndrome do not have fingernails. They bite their cuticles. Maybe it's an old scar. Maybe it's a mosquito bite from 10 years ago. Once you have an established favorite site, you want to monitor that area frequently for severity and signs of infection. The most common sites are arms, legs, the top of the head, fingers, cuticles, nails. It can take years for open areas to heal. Sometimes marks can mimic abuse. It can look like cigarette burns or other forms of abuse. Some causes of skin picking can be boredom, anxiety, task avoidance, dry skin or eczema, and bug bites. There are ways to lessen skin picking. You don't want to give attention to the act of skin picking because it can make things worse. You want to instead use distraction. You want to engage your individuals in activities, handheld games, puzzle books, board games. You want to remove the anxiety causing issue for them. Maybe they have money. Maybe you've got a new staff who's giving them extra food. Any breaches in food security, as Lisa already talked about, this causes high anxiety. High anxiety causes picking. Sensory stimulation is helpful in decreasing skin picking. I know Patrice out in Latham has had a lot of success with using sensory stimulation like vibration, brushing, regularly scheduled massages. And OT can help you devise a program to help with this. You want to lotion up your individuals to prevent dry skin. Dry skin causing causes itching. Itching can cause picking. Dressings on wounds. You want to try to make those as flat as possible. If you have an individual that skin picks frequently, the sheer act of them removing your dressings can cause that area to increase in size. Dressings that are not flat, any area that is not flat is a potential pick site. So when you put a dressing on that is not flat, they'll pick that too. Una boots can be helpful on the lower extremities. This is kind of like a half of a cast. The doctor will take a zinc pad and put the zinc pad over the area, the open area, and then they'll apply a lot of dressings wrapped up, and then a half cast, and then more wrapping. Also, to help decrease skin picking, you want to keep their fingernails trimmed. Insect bites, rashes, moles, blisters, dry skin, any orifice, scabs, toenails, fingernails, all areas that might be picked. Scars. I want to talk to you for a minute about this. If you have an individual that's going for surgery, you want to be sure to discuss with the surgeon that skin picking is a distinct possibility. There are a few ways that the surgeon can close the wound to make it flatter and a little bit more difficult to reopen the incision. Also, the way the surgeon closes or dresses the wound post-operatively, he can do a few things, or she can do a few things to make it a little bit more difficult to pick and make them a little less apt to pick. Now, rectal picking. So, as Mary Kay said when she gave me such a wonderful introduction, I've been doing this for several years. In all the years I've been doing this, I've heard a lot of people dance around rectal picking. I thought it was kind of this delicate little process like you would see when you're in the nursing home, but it's not. It can be quite involved. Our individuals actually find a way to contort their body for easy access to the rectum. In most severe cases, they can insert their hand and arm to the mid forearm inside their body cavity. It's nice to be the person right before lunch. So they'll insert their arm into their rectal cavity, and some of them are very, very dedicated to rectal picking. It can cause a lot of damage. It can cause rectal bleeding, rectal ulcers, infection, loose muscle tone in that sphincter, causing incontinence of stool. They can be misdiagnosed as having cancer. They can have mucousy stool. The most severe cases can require surgery and or a colostomy bag. And for those of you who don't know, a colostomy bag is where they create an opening in the abdomen that leads, they bring the intestines to the outside So their bowel movements would be had that way into a bag coming out of their side. Possible causes of rectal picking could be constipation. I overheard a talk that Dr. Ann Scheidemann did at one point, saying that you should consider keeping the stool of our individuals the consistency of mud. Miralax is very helpful in being able to create mud-like stools. Anxiety can cause rectal picking, frustration, itch, boredom. They need the stimulation. Idle time is the devil's workshop. Task avoidance, and huge shock factor. Your reaction to somebody who is rectal picking or skin picking, as far as that goes, can make or break some situations. If you are one of those people who say, oh, you've got poop all over your hands and all over your arms, and that's disgusting, get in there and take a bath, this is terrible, you could pretty much guarantee that you're going to see an increase in your rectal picking or skin picking. Certain red flags you should watch for that will tell you whether or not your individual is engaging in rectal picking. If they're spending excessive amounts of time in the bathroom, if they have bowel movement left on toilet paper, arm, hands, toilet handles or faucets after using the restroom. If you find blood in the bathroom, bloody stool on the toilet, fecal material under their fingernails, and in severe cases, you can hear the skin picking from outside the bathroom door. Once again, to stop rectal picking or to help decrease rectal picking, it's the same as regular picking. So I won't review these again with you, but I will stress again, do not make a big deal out of this. Usually what I'm seeing as far as when people do start to make a big deal out of these situations is it will increase and they'll raise the bar. Now you'll have fecal smearing and then you'll have some fecal eating. Each thing raises the bar to get your reaction to be a little bit bigger. Perhaps it becomes a game. The other thing is sometimes, and not always, but sometimes, it can be as easy as discussing the dangers with your individual and asking them how they would like help to stop. A lot of times they don't really want to do it. And sometimes this can be helpful, but don't count on it always working because it's pretty rare, I would think. Next, we'll talk about water and fluid intoxication, also known as hyponatremia. So a very simplified explanation, there is more to it than this, but a person drinks an excessive amount of water or fluid, and then it dilutes that sodium in your blood. And this can cause brain swelling, which manifests as seizures, coma, respiratory arrest, brainstem herniation, and death. Certain medications can cause this, but typically it would be drinking too much fluid. As with everything we discussed, not all people will develop this, but when you've seen it happen, you really don't want to take a chance on ever seeing it happen again, I assure you. There's a natural thought process we have about weight loss, and that is the more water you drink, the more fluid you drink, the better off you'll be. So chug down 64 ounces a day in addition to whatever else you're drinking that day, right? This could be way too much for a person with Prader-Willi syndrome. I've seen 80 ounces total of fluid cause sodium, or most of our individual sodium levels, to be at the lowest end of normal. I've actually scaled back a bit on the amount of fluid that our individuals receive as a result of this. Having said that, vigorous exercise, excessive heat, and sweating can cause the need for increased fluid intake. For example, you guys in Nevada who are at 120 degrees, a little different than us here in Cleveland who are probably at 60 degrees today. So your individuals are going to need more fluid than our individuals will need. You want to consider having sodium levels checked periodically by the primary care physician. And you also might want to consider having the full day's worth of fluid built into the menu. Our individuals tend to come home from visits with their family and they say, you know, my mom tried to get me to drink water And I told her, I can only drink what's on the menu. That is something that we've discussed for years and years, and I'm glad that they take it seriously. So building that into your menu can be quite helpful in preventing issues. Difficult IV access and difficult blood draws, because everything has to be difficult in the medical realm of Prader-Willi syndrome, right? So their veins are small, they're rolly, and they branch. They have many branches in them. And when I say branches, I mean legitimately like a tree branch where you see that they fork off. Well, when you're trying to start an IV in someone, or you're trying to draw blood work on them, you rely upon the straightness of the vein so you have a place for the needle to go. If it branches off, then you can go directly through the vein. So you want to warn the nurse or the lab technician that they have small, roly, branchy veins. A roly vein is when you attempt to stick the needle in the vein and the vein moves over a little bit so the needle goes alongside the vein. This results in them having to be stuck more than once. You want to also, in addition to explaining about their veins, you want to ask, can you use a butterfly? This is a very small needle. It's usually possible for blood work, but not always possible. It is not possible for an IV. You want to ask for someone who normally draws blood or starts IVs on children. You want to ask for a hot pack to hold on the vein for a few minutes prior to having the vein poked to increase the vein size. You can ask the employee to try only 2 to 3 times and have another person try. Sometimes they'll try 5, 6, 7 times, and you need to know that, first of all, that's not okay. And second of all, you don't need to be okay with that. You can actually ask for someone else. You can also see if the facility has an ultrasound machine so that the employee will be better able to visualize the veins. Next, I wanted to talk to you about some tips for dealing with your primary care physician. Not everybody is lucky enough to have a primary care physician that knows about Prader-Willi syndrome. You want to find a doctor that's willing to learn and teach them. You want to review that medical alert with them and encourage them to visit the PWS USA website. Develop a strong relationship with that doctor. Always arrive prepared with a list of any symptoms, strange issues, or behaviors that have just crept up. If the PCP has confidence in you, it can only improve the care that your individual is going to receive. You want to, during your relationship that you're building with your PCP, you want to always review the individual's diet and calories. You want to review the goal weight, any pick sites that are their favorite pick sites. What is their baseline temperature? You also should be reviewing, is this person an accurate reporter? I have an individual who has had a few urinary tract infections. And so our individuals hear bits and pieces of information and they like to relay that information. They can be hypochondriacal, and this can cause a problem. Anytime I have new staff, I get reports called to me. Oh, John Smith, he said that he went to the bathroom and his urine is green and he's peeing white blood cells and he can see them. Well, you should know it's not possible to see white blood cells in your urine. A lot of times he's looking for some additional attention. But your attending physician needs to know, is this person an accurate reporter? Is this person a hypochondriac? And then you also need to establish a means with that physician to be able to disagree with the individual without the individual knowing. Disagreeing with the individual in the middle of the appointment in front of them can cause some pretty significant behavior issues. So when he's saying, you know, oh, and I'm having all this pain when I urinate. I'm there every day. He hasn't reported to me. He hasn't reported to any staff. Odds are he's not having it. So I'm behind the doctor going, not happening. Also, copycat behaviors. Our individuals are very keen on copycat behaviors. So if Jane Smith dropped a box on her leg and got 25 stitches, now Susie Q needs to have surgery on her leg. She needs stitches too. Or if Janie went and got some antibiotics because she was having burning upon urination. Now the whole house is having burning on urination. So what are you going to take your individual to the doctor for? Any complaint that is not an emergency that you can't see, because this person has Prader-Willi syndrome, they're not going to manifest it in the same fashion that somebody without Prader-Willi syndrome would. So if somebody's complaining of, hey, my ear feels funny, you're going to go to the doctor. Obviously, these are not all the things you're going to take somebody to the doctor for, because I couldn't possibly list all of that. But sore throats, hoarse voices, runny noses, joint pain without swelling or bruising, and without a bone sticking out, so obviously you're going to the ER for that. If their weight drops below their goal weight. Now, a note about their goal weight. When you have your individuals on their diets for a period of time, they finally enter into their goal weight. What will happen after a period of time is they will all of a sudden just plummet below their goal weight. And then you're going to slowly start to increase their calories to get them back into their goal weight. Don't be afraid when that happens. It happens. I've seen it happen to every single one of our individuals. Any complaints of burning on urination or foul odor from the urine or increased frequency, you're also going to take that directly to the primary care physician. As far as the emergency room goes, there are several reasons to go to the emergency room. The following are a few definite reasons, but once again, not absolutely the only reasons to go to an emergency room. Any complaint of chest pain or abdominal pain, you're going directly to the ER. Loss of appetite. Now, if somebody pushes away their food or refuses food because they've got a behavior of doing this when they're upset, typically they're only going to miss one meal. Sometimes it's a control issue. This is where you need to know your individual. If your individual is all of a sudden truly experiencing loss of appetite, you're going directly to the emergency room. But if it's something as simple as, well, I'm mad and I don't want to talk to Susie today because she upset me, or I'm mad at you today and I'm not eating snack, that's not something obviously you're going to go to the emergency room for. Vomiting should be a trip to the emergency room, but do not confuse this with rumination or reflux. My rule of thumb is to my staff, was it a mouthful or more than a mouthful? Limb deformities, you're going to the emergency room for. If someone has a wound with bone or muscle visible, that's definitely going to be an emergency room visit. Any wound with a red, hot, warm area around it, it could be accompanied by a foul odor and drainage. You're going to the ER. Fever or low temperature, trip to the ER, and any change in mental status. So I've taken us down to the wire here. It looks to me as we've got just about 8 minutes. Navigating medical issues in people with Prader-Willi syndrome seems like a daunting task. But PWSAUSA.org has numerous resources that are available to help you, help the people you're serving. Arm yourself with education. You're the eyes and the ears for your individuals. Maybe somebody's engaging in a specific behavior at that time, and you're the only one that sees it. Don't be afraid to let somebody know. No matter how small your observation might seem, it could be extremely important. And go back to that example of the individual that said, my ear feels funny. Both of those eardrums were blistered a week later. Please, please don't lose sense of humor. Don't lose your sense of humor when you're dealing with our individuals. And I thank you so much for listening. Now I think we're going to open it up to questions.
We are. So Tina, thank you so much. That was so helpful and really well done. Just a reminder, if we probably have time for maybe one, possibly two questions. If you can electronically raise your hand, that makes it super easy for us. If not, you can just physically raise it and Katrina will be calling on you.
Thank you so much. So I see your hand up, Gail, and just to reiterate some things that happened in the chat throughout, yes, these slides are going to be available in the hub, as are all the other slides in the slide deck. Also the booklet, the medical alert booklet, that Tina referred to, you can get that at the PWSA USA website in the A to Z medical section, as well as in the app. Okay, so that is available for everyone. And we had, Gail, why don't you start us off with your question?
Unmute me.
We have to unmute her, yeah.
You're unmuted.
Okay. All right. I just want to know, has there been any opportunity to see any trends as it relates to individuals with PWS and COVID-19? Just is there a higher rate of it? How do they react to the vaccine or any of that? And one thing I think about is like the temperature. Since they don't have a temperature, that's one thing that's the first sign of COVID. But just any particular trends at all.
So I spent some time talking with Dr. Locher about this, and raising the point of the temperatures is excellent. What we were looking at as a possible indicator of COVID would be a pulse oximeter. So if the person's oxygen level drops below 90, then that might be a sign of, oh, Gail, I see a little French you got there. If the temperature or the pulse ox dropped below 90, then that could be a sign that there was some respiratory issues going on and possibly COVID-19 as a result.
Thank you, Gail, and thank you, Tina. Appreciate that. We also have a question from Eden, so I'm going to ask Eden to unmute.
Okay. Hi. I have a question. Our daughter, she actually was bucked off of a therapy horse, which seems very ironic, but whatever, and had to have the entire knee rebuilt. And what's really interesting is after working in the ER for I don't know how many years, feels like an eternity, but she showed absolutely no signs, no symptoms, just minor swelling. But then when I kept insisting, because she kept asking for more, more and more Tylenol, and I thought, okay, this is not like her. And ended up, she had ruptured the ACL, MCL, and PCL, tore both sides of the meniscus and cracked the patella, but said nothing in reference to her pain threshold. Most recently, just about 5 weeks ago, she rolled on a pine cone after we finished our walk right next to the car, fell and fractured her radial head. And no matter where we took her, that day we took her to urgent care for x-rays. And of course, her arm was probably too swollen for them to see. But, outside of taking Tylenol, she went to work for 4.5 weeks until they figured out that she had fractured the radial head right across. And so with knowing how high their pain threshold is, how do we determine when to take them to the doctor? I mean, for me, I've just learned if she asks for anything for pain, that's like an automatic give. What do you think?
I think you answered your own question. I think that that's an excellent indicator. And this is why, we're discussing with our providers today that, you're the eyes and the ears, and your individuals better than anybody, as you know your child better than anyone. So when something doesn't seem right, deep down, there's something that tells you, I need to get this evaluated. I need to advocate. I need to advocate strongly. And it's also very helpful when you have a good relationship with your primary care doctor, because there are times where I've actually called a primary care doctor from the emergency room because the emergency room doctors weren't listening to me and I knew there was a problem.
Exactly.
So yeah, great. You answered your own question.
Thank you.
Thank you
Thank you.
so much, everyone.
Thank you,
Patrice,
guys.
do you want to take it over?
Yep. If everybody could go to the attendee hub and fill out the surveys for each of the sessions, that is super, super helpful for us. And we will see everybody back here at 3:15. Thank you.
Thank you.